Yeah, but
It's still sharing.
it's sharing this.
Mhm.
I don't want it to
So
share.
here. You're sharing your screen, whatever is on there,
Okay.
not the actual.
All right. I'm gonna check the thing. To make sure. Can you see it now?
Yeah, pretty good.
Oh, wonderful session.
Okay, Christina, can you hear us?
Yes, I can still hear you.
Good. We'll go ahead and get started. Hello, everyone. This is our Improving Patient Care Through Data track. Our last session of the day will be titled Gipper Overview. I'd like to introduce our presenter, Christina Rogers. Hey, Christina. Christina Rogers is an employee of the Nashville Area Indian Health Service and has been there since October 2005. She is a certified clinical documentation expert for outpatient services, professional coder, biller, and auditor, as well as an AAPC approved instructor. She works as the Nashville Area Statistician, Government Performance and Results Act Coordinator, Health Information Management Consultant, HIPAA Privacy Act Liaison, is one of the improvement advisors for the Nashville area and provides medical coding and auditing training for federal, tribal, urban locations nationwide within the Indian Health Service. Thank you for being there, Christina.
Thanks, Brian. And I apologize for not being in person. I know we are in Nashville and I'm in Nashville, but I was exposed to somebody that had COVID. So out of abundance of precaution, I decided that it would probably be better for me to present virtually. So I'm sorry that I can't see you all in person. I was actually looking forward to it because I haven't seen a lot of you in at least 2 or 3 years. So, but at least you get to see my face. And we will get started. So we're going to do a Gipper overview. Next slide, Brian. We'll just talk about some general information about GPRA. For those of you that use RPMS EHR, we'll talk about some local system reports that you can run. We will go over the logic, not in super detail because it's very long and boring, but I'm going to kind of give you some highlights of each of the measures and the logic. We'll talk about the national system reports. Those are those ITSIS, the Integrated Data Collection System reports. And then we'll talk about some strategies for improvement. Next slide. So GPRA stands for Government Performance and Results Act. It is a federal law. It came into fruition during the Clinton administration. During the Bush administration, it was transformed to have more budgetary strings where basically it required all federal agencies to have a data-supported audit trail for the appropriated dollars to the activities and customer benefits and outcomes that were consistent with the agency mission. So basically, Congress wanted to know, what are we doing with the money and how is it impacting our customers? Next slide. Under the Obama administration, it was transformed again, sort of. And so what you'll know or what you'll hear refer to as the GPRA MA, so GPRA Modernization Act of 2010. A lot of people use GPRA and GPRA MA interchangeably, so you may hear either term, but the difference between them is that the GPRA MA legislation strengthened the original law, and it basically singled out certain measures that are now reported to Congress that we have to show performance data to show that it is helping us make decisions with how we're treating our patients and how we're using our funds. So for next slide. So for 2022, and actually for the last, I want to say 3 or 4 years, the intimate partner violence, domestic violence screening is the GPRA MA measure. And that has been, like I said, for the last few years. That is the only measure right now that gets reported to Congress for our GPRA measures. The rest of them become budget measures. For 2023, we will add in the influenza vaccine for the 18 and older. The last few years have been a little tough with the influenza vaccine, just with COVID and COVID vaccines. So as we go into the fall, usually people start giving shots end of September, beginning of October, depending on when you get your stock of medications in. But you really want to make sure we're doing a push for that influenza vaccine because in 2023, it is one that we will be reporting to Congress. Next slide. So I mentioned that the remaining measures, because if you're familiar with GPRA, you know that there can be anywhere from 20 to 27 measures per year, depending on the year, depending on what's being reported. So the rest of the measures are tracked and reported as part of our national budget request. So they're still as important because if we can show as an agency that we are improving patient outcomes, that our rates of screenings are continuing to increase, and that we are moving towards preventive medicine, those types of things, there's always a potential that we could get some additional funds for the agency in relation to the care that we're providing to our patients. Next slide. So GPRA is important because it can potentially affect funding for tribes. I will tell you that tribes are not required to report for GPRA, but we thank you because most everybody, with the encouragement and help with from USET, most of our tribal locations do report for GPRA, which helps our area and the agency in the long run. Federal sites and urban programs are required to report GPRA measures. But again, those tribal sites, it is optional. But as long as I've been with the agency, all of our tribal partners have chosen to participate in reporting GPRA measures. So we thank you for that. GPRA can also be used for quality improvement activities. If you feel like the data that is being pulled out of your system is not really reflective of what's going on, there could be a data entry problem, there could be a documentation problem, or there could be maybe a workflow problem. So it's a really good tool to help you kind of look and see different ways that you could improve efficiencies in the clinic, outcomes for patients, and those types of things. And then hopefully, because most of these GPRA measures are preventive care measures, the hope is that down the road, it could potentially decrease the cost of caring for these patients. For instance, if we catch colorectal cancer screening early, that's way cheaper getting having a colonoscopy, getting some polyps removed, versus somebody who has full-blown colorectal cancer. So a lot of the GPRA measures are preventative screening type measures that we hope down the line we can prevent patients from having any serious complications or more serious diseases. Next slide. So now we'll talk about how GPRA is measured. So next slide. So I get the question a lot of how are these measures selected? Who decides that? So just kind of very, very briefly, there are subject matter experts at the headquarters level of the Indian Health Service that do determine the logic for the measures. They determine which measures we're going to track. There is some consultation with the Office of Management and Budget because they approve any changes that come through. So the GPRA measures, especially, they will approve any changes. The addition, like with the influenza measure, typically the agency tries to find measures that are relevant to our population. There may be some emerging areas of clinical concern. If they are not put into a GPRA measure or a budget measure, there is another bucket called the developmental GPRA measures. And so those are also sort of tracked. These are things that aren't reported necessarily outside agencies or to Congress, but they're tracked by the agency in case they may eventually become a budget measure or eventually become a GPRA measure. Next slide. So there's 4 different buckets. There's diabetes measures, dental measures, immunization measures, and then preventive care measures, which I'll go over those in a later slide. Before we move on to the local systems report, I just want to see if there are any questions about sort of the administrative things related to GPRA.
No questions?
Okay. All right, so I'm just going to briefly touch on some local system reports, and this only applies to those locations that are utilizing the RPMS EHR. Next slide. So in that system, there is a package called the Clinical Reporting System, also known as CRS. It's the same at every place that uses RPMS EHR. It produces reports on demand. It saves us from having to do manual chart reviews, which there was a time when we had to do manual chart reviews. I think some of you still might be doing that for diabetes audit reports, but the CRS report really kind of helps cut down on that extra time having to do those manual audits. It is updated on an annual basis. Typically throughout the year, there will be 2 updates to the logic. The first one typically comes in February. The next one typically comes in June, July. And it is the same at all locations so that we can do some comparison between site to site, area to area, and then so that we can combine the information when we report it to Congress. Next slide. So this software basically does a scavenger hunt. It is looking for a specific set of people who are the denominator, and then a specific set of people who have met that particular measure, which is what encompasses the numerator. Whenever possible, we try to utilize standard industry code sets. So for the RPMS EHR sites, that's going to be SNOMED, ICD-10-CM, CPT, LINC codes. And then there are some IHS standard code sets like health factors, patient education codes. Non-RPMS sites, you guys are going to report your data using ICD-10 codes, CPT codes, and then LINC codes as submitted through your data exports. Next slide. And like I said, it basically is just looking in the system to see, does this person meet the criteria to be counted? If they do, did they have this service? And it's basically a yes or no. It's documented or it's not. And I say that it's documented because a lot of times people will have the service, but it may not be documented in the right spot. It may not be documented using the right code. So that's why I mentioned earlier that a lot of times these reports can be utilized for quality improvement work when it comes to documentation improvement or utilization of proper codes. So in the CRS package, there are groups of taxonomies. It looks specifically at lab, medication, and community taxonomies. The community taxonomies are based off of your service delivery area because only the people that are part of your user population, which is people who have had 1 visit in the last year, who are American Indian Alaska Native, and who live in your service delivery area. Those are the only people that are counted for GPRA. So I got the question quite a bit during COVID. If patients who don't normally come for services came in for a vaccine or a lab test, if they would be included in the denominator. And the answer to that is maybe. It depends on where they live. And of course, if they're American Indian Alaska Native. Next slide. So I always like to put this disclaimer in here that the CRS software is just that, it's software. It's not something that's going to fix any workflow problems that you might have at your facility. If people are documenting things incorrectly, it's not going to help. It's not going to fix those things, but it can help you identify those problems. So it can be utilized as a quality improvement tool. Next slide. So in terms of involvement, go ahead, next slide. Everybody has a role. I have never seen any location meet their GPRA measures without it being a collective clinic project or performance. The providers are the ones that are assessing and providing care. They're documenting correctly in the system. Coders are accurately and completing the coding, making sure that if there are any of those ZZZ.999 codes, that they are updated to the proper codes. A lot of places will do things like pre-visit planning, utilizing health summaries, patient lists, CRS forecast reports, so that they can monitor progress and when patients come in for visits, so that they can see what services they need before they're actually sitting in front of the provider, because we all know that we have limited time slots. We have limited time with our patients. So we do want to figure out an efficient process where people are screened for services, information's entered in the system, but they also get that time with our care providers. Next slide. So the next couple slides are just some examples of some reports that you can run from the CRS package. The first one here is a patient list. So if you're doing any type of outreach to patients, say for October, you wanted to do outreach for people who needed flu shots, you could run this list, produce some material and mail out to people, just letting them know, hey, we have flu shots now, or it's a great time for you to come in. But this is a good tool that you can use to get a list of people who are in the denominator for GPRA and who have not yet met the measure. You can, I don't have a screenshot of this, but you can also use iCare for this. A couple caveats is that depending on how you build your panel, it may not match the CRS logic. And then the timeframes for iCare are different. They go back a full year from the day that you run the report, whereas the GPRA CRS reports are always going to go back to the beginning of the fiscal year, which is also the GPRA year, October 1st to September 30th. Next slide. So the next one, this is one of my favorite ones, is the forecast report. You can run it by appointments. You can run it by panels. You can run it by just ad hoc if somebody walks in. Next slide. And it basically looks like this. So it'll pull up for each individual patient what measures they've not yet met for that particular GPRA year. So it's a nice tool. A lot of people will use this if they have appointments coming up tomorrow. At the end of the day today, they'll run the list so that when the patients are in tomorrow, they know exactly what they need to do. So they are prepped to ask patients, do you want a flu shot? We see you haven't had a pap smear. Do you want us to work with you to schedule one either internally or through our PRC program? But it is a great tool. Again, you can use iCare for this. Just know that the timeframes might be a little different. I have seen where patients will meet the measure in either iCare or the CRS report and not in the other. Just depends on the timing and when the reports are run. Any questions before we jump into the logic? Okay. So I'm going to go over the logic, just the highlights, because you could go into the rabbit hole with all these. So I'm just going to give you some highlights. We'll go over the measures. These are the measures for 2022 that I'm going to talk about. Although I will tell you that the measures for 2023 are going to be the same. There's a couple measures which I'll mention that are going to have logic changes for 2023, but it'll still be the same set of measures that we'll be talking about in the next year. Next slide. All right, so first are the dental measures. The access to dental services, there was actually a little bit of debate about this amongst a few sites as to what constitutes meeting this measure. So the logic actually says that the patient has a documented dental visit. Doesn't necessarily need to be an exam. So tele-dental services count for this particular measure as well. So if I know a lot of places close their dental services during COVID or are starting to ramp up, if you have the capability of doing tele-dental services, then you can still get credit and bill for those services as a dental access. I believe I want to say it's this D9995 code, might be 5 and 6. These two codes kind of in the middle. I believe those are the tele-dental codes. So if for some reason you guys have to shut down your dental clinics again, keep that in mind that you can still get the credit for access to service by doing those tele-dental services. And that particular measure counts all patients that are part of your user population. Dental sealants is next, and that one is looking particularly for patients with at least one or more intact dental sealants during the report period for the ages 2 to 15. A lot of patients have intact sealants or don't need sealants. If that's the case, we want our dental staff to use this tracking code, the 0007, because basically what that does is it indicates that you looked, but they don't need any sealants. So you still get credit for that. For topical fluoride, those are patients that are 1 to 15, just looking to see if there is a topical fluoride received during the report period. Depending on your location, if medical staff are properly trained, topical fluorides can be administered by medical staff. Some places that maybe don't have a dental clinic or a large dental clinic have employed nursing staff to do this if they're trained properly. So that is always an option. Next slide. So next we'll start with the diabetes measures. And one important note for the diabetes Gipper measures is that it is looking for patients who were diagnosed with diabetes prior to the report period. So they have to have diabetes, a diagnosis of diabetes before October 1 of that year. If they get diagnosed, say October 2nd, they are not going to be part of this Gipper denominator. So if you were to pull up a eye care panel for diabetic patients, they would be listed there, but in there, in the eye care panel, it's going to say NA because they don't meet the criteria for being diagnosed prior to the beginning of the year. Another little caveat. The blood pressure control for diabetic patients, we're looking for them to be in control with a blood pressure of 140/90. Both the diastolic and systolic values must be below 140/90 in order to count. And the system basically does a average of the last 3 or 2 blood pressures. If there's only one, then it takes that value. The nephropathy assessment is looking for an estimated GFR and a urine albumin to creatinine ratio. It's got to be both. So this is one where we want to make sure that our taxonomies are up to date so that the reports are reflective of the services that we're doing. Next slide. The glycemic control, we are tracking poor control, which basically we want this rate to be as close to 0 as possible, because we're looking for patients that have an A1C greater than 9, and we don't want a lot of patients in that category, right? So this is one that should be as close to 0 as possible. It basically looks for the last test for when the data was grabbed. The retinopathy assessment is looking for a diabetic retinal exam or another eye exam. Essentially, if they've had a service from an ophthalmologist or an optometrist, it'll essentially count. We have seen, though, where sometimes those individuals might come on site as like a contractor, and instead of documenting in our system as a diabetic retinal exam, they're just putting it as an eye exam. So if you notice that your retinopathy assessment numbers are kind of stagnant and you feel like they should be, a little bit higher, or at least fluctuating some, you might look and see how things are being documented, because we did find at one particular location that they were being done, but they were being documented as just regular eye exams instead of diabetic retinal exams. Next slide. So next we have the statin therapy. And this, again, is those diabetic patients that were diagnosed prior to the report year. And we're just looking to see if they had any type of prescription to a statin therapy, to some type of statin, whether it was prescribed by an outside provider. Some patients have endocrinologists that they see outside of our systems, or they may have another primary care person that they see. And maybe we were the only ones that were open when they were sick, but now they're in our denominator. So we do need to get that information. So outside medications count. If they are prescribed through our system, of course, that's going to count as well. And then there are some exclusions and exceptions that take people outside of the denominator for this particular measure. Next slide. So next we're going to move into the immunization section. So the adult immunizations, this is patients that are 19 and older, and there's 3 different buckets. The 19 to 49 years is the 1 Tdap TD in the past 10 years, and then 1 Tdap ever. I can tell you that that is usually the easiest age bucket to meet. just because there's only those two different measures. I'm sorry, two different immunizations. The next bucket is 50 to 64. It includes the ones from the 19 to 49, plus the 1 dose of Zostavax in the past 5 years, or 2 doses of Shingrix ever. And then the last bucket is the 65 and older. It uses both of the age buckets before, but adds on the up-to-date pneumococcal vaccine. And I will tell you that that one in particular for 2023, the logic will be changing. Recently, there was an update to the vaccine recommendations across the different age groups. And so it's going to include an updated zoster vaccine guideline, which is the 2 doses of recumbent zoster vaccine. And then there is another change. Let's see. It'll also include the 2 doses of Shingrix. So for 2023, that one will change a little bit, but it'll become a baseline measure. So it's a little bit easier to meet. It is an all or nothing measure. So the patients have to receive all of the recommended vaccines in order to meet the measure. Next slide. Childhood immunizations is next. This one's very similar to the adult immunization. I think most of us are more familiar with the childhood immunizations, but it's looking at the four DTaP, 3 polio, 1 MMR, 3 or 4 Hib, depending on the manufacturer, 3 hepatitis B, 1 varicella, and then the 4 pneumococcal. Usually what I've seen is it's that 4 pneumococcal that's holding us up. It also matters for the Hib if the patient starts with one version and switches to another version, like one manufacturer, and then switches to another one. The system doesn't understand that, and it won't count them as meeting the measure, even if they got the recommended number of immunizations. The influenza vaccine, basically 2 measures, the 6 months to 17 years, and then the 18 and older. The 18 and older one, like I mentioned, is going to be a GPRA measure in 2023. So we do want to try to make a push for that one. Next slide. So the cervical cancer measure is next. This one is actually a baseline for this year in 2022, because what they did is this year they added the last little sentence here where it has the HPV primary in the past 5 years. So for the female patients 24 to 64, we're looking for a pap smear in the last 3 years, or a pap and HPV DNA in the last 5, or that HPV primary in the past 5 years. So for 2022, it's a baseline. For 23, it'll be, the rate will be based on what the agency baseline was for this year. The childhood weight control measure, that is a long-term measure. We reported it in 2021, and we'll report it again in 2024, but we're still tracking it because it's not really one that we typically see change in year to year, which is why they changed it to a 3-year measure. But it's basically looking at patients that are 2 to 5 that have a BMI that could be calculated that is at or above the 95th percentile. So this is another one that we want it to be as low as possible, want it closest to 0. And the height and weight must be documented on the same day in order for it to count. The colorectal cancer screening for 2022 is a baseline measure as well. This year we changed the age from 50, it used to be 50 to 75. In 2022, we changed it from down to 45. So 45 to 75. There are lots of options for this one. You could do the FOBT or FIT during the report period. So that's an annual one done once a year. You could do the flexible sigmoidoscopy or CT colonography in the past 5. You could do the colonoscopy in the past 10 years. And then you can do the FIT DNA in the past 3. So this has come up recently at a few sites. The Cologuard fits into the FIT DNA bucket. So if you're a location that starts to utilize that, you need to make sure that the lab gets built into your system so that it can be entered appropriately. Next slide. So next is the controlling high blood pressure, the million hearts measure, and this is patients that are 18 to 85 that have hypertension. So you may have some patients that are diabetic that are in that diabetes measure fall into this measure as well if they have hypertension. So if they do and you are able to screen them, then you're kind of getting two bangs for your buck. Because it's basically the same, looking for patients that have a blood pressure less than 140/90. Next slide. The statin therapy is very similar to the diabetes one as well. It's just a larger age group and kind of a bigger bucket of patients. But again, those outside medications count if they're prescribed inside. If they have some type of contraindication to a statin, that needs to be documented as well. And this is for both the diabetes and this measure, because what it does is it takes them out of the denominator. Next slide. Depression screening, there are two measures, user population patients 12 to 17 and then 18 and older. Just looking to see if they were screened for depression. Now, we do recommend that you utilize the PHQ-29 or T. A lot of places are using exam code 36. That is okay right now, but at some point, if they change to looking at the results of the screenings, the exam code 36 is not going to cut it. The results of that particular exam is not getting exported to the data center, but the results of the PHQ-29 and T are. And then also if you utilize any of the ICD-10 codes or CPT codes, those do get counted and exported as well. The breastfeeding measure is looking at patients that are 30 to 394 days old to see if they were screened for infant feeding choice. If they were screened, only those that were exclusively or mostly breastfed count for this measure. I will tell you that the past maybe 6 years, there's been kind of a decline in this. It's quite possible this will increase with all of the issues that mothers had this year with the formula shortage, right? So any new moms may try to breastfeed a little bit longer or start with breastfeeding. So we definitely want to make sure that we are documenting that information in our system. The HIV screening is patients that are 13 to 64, and we just want to see were they screened at some point, one time at least, before the end of the report period. So this one, if you were screened at 13, you still are counted as meeting this measure at 14, because we're just looking to see if they were screened ever. Next slide. The intimate partner violence, domestic violence screening. This is for female patients 14 to 46. I should have mentioned this earlier, but GPRA is kind of considered a minimum standard of care. So some of the measures that I've gone over are limited to specific age groups or female, mostly it's female population. But we do understand that everybody can experience intimate partner violence. So we do recommend for depression, intimate partner violence, alcohol, and tobacco, that every patient, every visit gets screened at least every 3 months because life happens, things can change. One minute patient might not be depressed, something happens, and then now they are. So we do want to make sure that we are screening patients appropriately, especially also with the intimate partner violence. This one, most places are documenting with exam code 34. Again, that's okay right now until and if the agency decides to start looking at the results of the screenings. If possible, we recommend that the education codes be utilized as a way to document that the screening was done as well. Even if the patient says no, unfortunately, the only way to document the no's is with this exam code 34. The mammography screening is next, and this is patients 52 to 74. And it's just looking to see if they had a mammogram in the last 2 years. Next slide. The universal alcohol screening. So this is patients that are 9 to 75. And this is one where we recommend that you utilize the cage factor. Again, a lot of people are using this exam code 35, but the result of that does not get sent to the data center. So I have seen some sites on the RPMS side, they've met the SBIRT measure, which I'll talk about next, but at the data center at ITSIS, they've not met it because they're using this exam code 35, and the result of that does not get exported. So we recommend that you utilize a cage factor, the audit C, or the craft. For cage, anything other than, that's fine, Brian, you can go to the next one. So for cage, anything over 0 counts as a positive. So those patients would need to have a documented intervention, brief negotiated intervention, or referral to treatment within 7 days of that positive screening. In 2023, this is the other measure that will be changing. They are adding telemedicine visits to this logic, which is awesome because it is a lot easier to call somebody or schedule a FaceTime or WebEx, some type of audio visual, or just a telephone call to provide some type of intervention and referral to treatment. Sometimes I've seen where people can't get them into a face-to-face visit within 7 days and they're not able to provide those services. So adding in the telemedicine services, I think, is a game changer for this. The tobacco measures are next. So for use and exposure, that is documented using the health factors, and then providing education. If a patient quits on their own, we want to make sure that we document that they have quit, because you guys get credit for that, even if you did no intervention and they quit on their own. For the tobacco cessation, we're looking to see if there was either some education provided. Typically that's documented under the wellness tab, or for dental, because a lot of times dental is providing that education. If they use the 1320 code, that counts. And then any education that is in the tobacco categories counts for this measure as well. Next slide. All right, any questions before we move on? I know that was kind of a quick and dirty overview.
We do have one from Leslie Willis
Okay.
on the chat. Can you hear me?
Yep.
Leslie mentioned if the reminders in this section, sorry, let me just read it verbatim. Are our reminders section of EHR updated automatically for these each year, or will we need to add these individually?
So that is a good question. And I will tell you, Leslie, that those are not updated on a regular basis. The reminders that are in the system right now are old. They're from 2017. There's not been an update to it. So the reminders in the system, unless you are doing local reminders, do not include the current logic. We have been hearing since March that they are coming out with new reminders. And it was supposed to be a release date of May, and then it was June, then it was August. We are not hopeful that they will get released by the end of this fiscal year. The staff member that was in charge of that left, and then because COVID and everything, they weren't able to fill that position until about a year ago. So the reminders in the EHR right now are pretty much broken. The codes that are current are not part of the logic. So we have heard where people are getting frustrated using the reminders because they're not turning off, right? Because you're providing the service, but they're not turning off, and it's because the logic is old. And unless you are building your own local reminders and updating those on a regular basis, they won't update until that new patch comes out. And we keep hearing it's coming. I would guess at the earliest for the RPMS EHR sites, it's probably not going to be until November, if that.
She had a follow-up question on if we remove the old, or will they do that? But I believe you answered that.
Yeah. So once the new patch comes out, it'll just overlay onto the old ones. You might have to reactivate them. But Robin Bartlett will be the one to install those at your locations. So once they're available, we'll definitely let you guys know.
Thank you.
All right, so the next section is the National System Reports, also known as the National Data Warehouse or the Integrated Data Collection System, also known as ITSIS. So basically what the National Data Warehouse is, it's a central repository where data from RPMS sites and non-RPMS sites gets sent. It produces workload reports, user population reports, and then as of, I think it was 2018, Gipper reports as well. Next slide. So the thought was that it would reduce the burden for sites running Gipper reports. That was never an issue for the Nashville area because prior to me coming on board, I believe way back when, I don't think she's in the room, Angela used to run these reports for you guys. Angela Snell used to run these reports when she left for a little bit and I kind of took over that. So it's never really been a burden for the Nashville sites, but outside the Nashville area, it definitely was. It also allows the non-RPMS sites to participate in Gipper reporting. So prior to 2018, if a site did not utilize RPMS EHR, they were not included in our reports. And as more sites decided to get off of RPMS, the agency had to figure out a way to start including them if they wanted to participate. And so the centralized data mart, because they were already sending data for workload and user population calculations, was basically the best solution. Next slide. So the results of these reports are based on when data is exported. It does utilize the official user population data. So what happens is there's the previous year's user population is utilized up until about April. Starting in April of every year, they start doing draft user population reports for the current year. So we typically see a change in the numbers in April, in June, in August, and definitely September because the user population updates. It does follow the fiscal year, so it's still October 1st to September 30th, but the data is only as current as the last export. So next slide. So for the RPMS EHR locations, there's an automatic export for you set up to go on the 22nd of each month. There's a few larger sites and then the federal sites that have an export that goes on the 8th of the month. So when we send out the Gipper reports on a monthly basis, you'll notice that there's 2 dates. There's a date for the RPMS report and then a date for the ITSIS report. And that's because the ITSIS data is typically 2 to 4 weeks behind the RPMS data, depending on when the last export was. For the non-RPMS sites, it's going to be based on the last time that you sent data. And it has to be loaded into the data center at least 8 days before the report. So they update that report every Tuesday, but let's say you sent your data on Friday, we wouldn't be able to see it for another week or so because there's an 8-day period. Next slide. So in terms of export deadlines, in the past, there were 2 different ones. And I think the original slide set that I sent to you guys for this presentation had some different information. I actually just got some breaking news last week. So this is the most updated. So Brian, I don't know if it's possible to share this slide set with the group whenever you guys share presentations. But the workload and user population deadline is October 26th. That is also the deadline for Gipper data. In the past, they used to let us submit data for Gipper all the way through mid-December. They decided to make it all the same. So for the current fiscal year, all data submissions related to workload, user population, and Gipper need to be sent by October 26th of this year. Next slide. So some things that they're still working out at the data center, people with shared PERCDAs. We still can't separate things out by particular service units. This is primarily because user population is based on where people live, not where they seek services. So they're still working on that. They're still working on how to separate out the urban user population, because we do have a couple sites that overlap a PERCTA with an urban program. So right now, it just looks like the urban programs aren't doing anything because their people are getting counted in the tribe's user population. So they're still trying to figure out how to separate that information. Next slide. So all of that said, mentioned about the national data warehouse, national reporting, nothing really changes locally. So if you're on an RPMS EHR site, the software will continue to be updated. You'll get it does update typically twice a year. Again, usually February and then usually June. Your local processes are going to be the same. You still want to have regular team meetings, run patient lists, utilize forecast reports or iCare, provide those services to patients that need them. Make sure you're cleaning up the coding queue and running error reports. If your coding staff is way behind, that's going to impact your reports. So you want to make sure that, usually there's about a 4-week backlog, and that's normal. Some places are further behind, but definitely working on cleaning up any errors in the system will help improve the rates. One other thing is that the numbers that are produced on the local system will be different than what is produced at the data center. Some of that is a timing issue. Like I mentioned, the ITSIS data is going to be 2 to 4 weeks delayed. But the RPMS data, if you run it today, it's going to be current as of today. The other thing is that the ITSIS data is using the official user population, which is different than what our local system user populations can produce, simply because the National Data Warehouse is doing area-wide unduplication. So patients may visit multiple clinics, but they only get counted one time at ITSIS. But in the local system, they could be counted multiple places depending on where they live and they're closest to another clinic. Next slide. So we'll still continue to run CRS RPMS reports on a monthly basis. We do pull the ITSIS data on a monthly basis as well. In 2023, we will add a section that has the ITSIS numerator and denominator. For the RPMS sites, of course, the non-RPMS sites, you already get that. I do get some questions sometimes as to why the rates are different. I think this will help explain a little bit more, just because the denominators are different or their numerators are different. And then if and when the data warehouse is able to produce service unit reports, we'll share those, but we've been asking for those for about 5 years and they keep telling us they're working on it, but we're not hopeful. So we will share, we try to share everything that we have available to you guys to help you in your improvement journey. Next slide. Any questions on any of those before we move on?
Nope, we're good.
So next is just some strategies for improvement. So of course, coding clinical staff, data entry staff, you want to make sure that you have a process for entering that outside medical data. A lot of our locations send people out for PRC services because they don't do things on site. We need to have somebody that can track down those reports and make sure we get that information back and then make sure we enter it into the system. Next slide. So some places will have the provider review that information and enter it directly into the EHR PCC. Some places will have the provider highlight clinical things of clinical importance and then have medical records enter it. Either way works. We do have some data entry cheat sheets. Go ahead and go to the next slide. We have 3 different versions. So the one on the, I guess, left, I'm not sure what's mirrored on your side, but the one that's right directly under the cheat sheets header is for non-RPMS sites. This has the actual ICD-10 and CPT codes listed. Not the RPMS sites are more than welcome to utilize this as well if they want to make sure their pick lists are built appropriately. The one in the middle is specific to our PMS EHR sites. It tells you kind of where to document things in the EHR. And then the one on the far side is some instructions for entering into the PCC data entry. If you would like a copy of these, I think there was going to be a sign-in sheet for those of you in the room. And I guess if you're online, you could type it into the chat. If you would like to receive these, or you may have received them earlier in the year. They've not been updated for the 23 logic yet. They still have the 22 logic, but those are available to everybody. Next slide. You want to make sure that you're entering historical data. That definitely counts for GPRA and the diabetes audit. I know some sites that use COTS products are having some difficulty getting that historical data sent to the data warehouse. So if you are one of those sites, just continue to work with your vendors to see if they're able to adjust the export logic. But we definitely want to make sure that historical data is entered into the system. Next slide. We also this year created some recorded trainings and PowerPoints. Usually we do a Gipper overview similar to this at the beginning of every calendar year. And what we did this past year, which we will continue in the next year, is we made quick little snippets because sometimes it's easier to sit for 3 minutes versus an hour if you have new staff and you're learning to, training. So what this is it's just a quick recording of how to document in the system, where to document, what the logic is. We do have one for non-RPMS sites. However, it just includes general information about GPRA because we don't know your systems and we're not able to do screenshots and whatnot. So if this is something you're interested in, let me know. Like I said, for 2023, we will produce something very similar and get that out to the field as needed. Next slide. It's important to make GPRA a priority. You want to align it with your organizational goals. It shouldn't be a burden, right? It should be something that we are providing to our patients because it's part of the services that we provide our patients. I don't know how many times I hear that we can't fit it in. If we make it a standard practice that this is how we do business, then it's possible to fit it in. I understand there are lots of staff shortages, people are stretched thin, but we do have some sites that are fairly successful, large and small, very different sizes, capacities of staffing. So it can be done. It just may take some finagling and figuring out different processes, workflows to see what might work better. It's important that you look at your data on a regular basis. I mentioned a few things. If the data feels wrong, it probably is. It could be that things are not getting documented correctly. It could be that people are not getting registered correctly. They may be listed in a community outside of your service area when they actually live in your service area. There's a lot of things that could impact it. So you want to look at it, and if it feels wrong, let us know. We can take a look and we can dig a little bit deeper. Sometimes if it actually is accurate, just that peace of mind to know that somebody looked at it and verified that, no, I'm sorry, this actually is right. Just kind of helps, and it makes it a little more usable if you're able to do that. You want to use a team approach. A lot of places will do weekly or daily huddles, have monthly meetings. You want to coordinate care between providers and then define roles and responsibilities. Next slide. You want to identify patients that need services. Lots of ways that I mentioned you can do that. Max pack visits when it's appropriate. We don't know when our patients are coming in. I'm one of those bad patients that I only see my doctor when I'm sick. So when I go, they ask me a million questions because I'm probably not coming back again for the rest of the year. So if they're there, provide all services that are appropriate, see if they want referrals for things, those types of things. That way you can at least try to get them the services that are part of their GPRA repertoire. Next slide. Postcards or letters inviting people to the medical clinic or dental clinic are great things. I know a lot of places have started to do health fairs and community events. Those are great places to get information as well. And then one of the biggest things is just make sure that you're following up on test results to make sure that that information gets into RPMS. Even if you're using a lab interface, sometimes they break or turn off or something happens. We want to make sure that those lab results are actually getting into the system, even if we have to manually enter them. Now, if patients are getting labs outside of your system and you're able to obtain a copy, then you can enter that information into the system. I will tell you that when it comes to historical data entry, pretty much everything except for lab results can be entered through the EHR. The lab results have to be entered through the PCC data entry module. So, you want to make sure that people are trained in how to do both. If you have questions about that, let us know and we can provide some training for you. Next slide. So this is what the area data looks like as of 7/25. And it's actually been updated since then. So I have some more current numbers, but I had to get the slide set in. So it was refreshed and now it is showing that we have met the topical fluoride, the nephropathy assessment, the poor glycemic control, the statin therapy for diabetes, the depression for 12 to 17, as well as the 18 plus, and then the intimate partner violence. So as of this morning, because I checked this morning, the area is showing that we've met 11 measures. So hopefully that'll continue to improve. Next slide. So this is what the FY22 and 23 targets look like. This is half of them because they wouldn't all fit on one slide, but you can see that for 2023, for a lot of them, not all of them, the rate is lower. So they have taken into account the fact that we've been in a pandemic for the last 3 years almost, and that our services really have suffered because places are closed. People aren't coming for services. So for 2023, the targets are a little bit lower for most of them, not all of them. You can see nephropathy assessment and retinopathy have increased, but everything else on this slide has decreased. Next slide. And then the pap smear, it's a baseline, this pap smear and colorectal cancer screening baseline for 22. We're just going to maintain that for 23. Mammogram drops almost 10%. The SBIRT measure becomes a baseline measure, and pretty much the rest of them decrease a little. So I'm hopeful that in 2023, we should be able to meet more measures. I think in 22 as an area, we should be able to meet more than 11 as well. We've got a couple more months. So if you have anything left, any outreach you want to try, now that kids are going back to school, it might be a great time for immunizations, screening measures. Even if the patients are minors and you notice that their parents that brought them in haven't been screened for things, great opportunity to screen them for any behavioral health things or get them set up for referrals. Next slide. And that is the end of the slide set that I have. My contact information is listed here, phone number and email. So if you have any questions after the fact for today, please reach out. I'm always willing to answer questions and help out. So thank you guys. I hope that wasn't too boring.
I have a question. Can you hear me from here?
Yes.
Hi. Yeah, I saw that you're also a privacy officer, and I saw that, one of the improvement strategies was postcards and letters that RPMS can put out. But are any of the sites in Nashville area able to, since the feds are more constrained, are they any of them using texting or other ways to message patients to try to coordinate care?
No, so federal programs are not allowed to do any of that. Of course, tribal programs, you guys have a little bit more leeway. You definitely want to make sure that you have policies and procedures in place written down for any of those types of communications with patients. You also want to make sure that it's typically recommended that people don't use personal phones, that they use a company phone for any of those types of services. And then on a periodic basis, you need to make sure that all the data from those devices is wiped, just to make sure that things are not kind of kept. But yeah, for federal programs, we're not allowed to use any type of text messaging, even just hey, you have an appointment, not, hey, you have a pap smear. But just the appointment reminders, our offices and our clinics are not allowed to do that. But tribal programs have more leeway. You just want to make sure that you have all those HIPAA privacy things laid out. You want to make sure you're using a appropriate HIPAA compliant software or system if you are texting your patients those types of information.
I don't think any of the clinics are doing. Anybody else?
Yes. Christina, this is Steve with Gipper Modernization, and we just are finishing, or we're in our first full fiscal year of operation, the new clinic. And just in preparation of supplying this data, how we do not use our PMS, we use a third-party software. What is the format in which we need to provide data to you?
Yeah, so interesting that you bring that up. So we actually are in the process. So there's a few things that you have to have in place. You have to have a service unit. You have to have a facility code, which is also known as an ASCII-FACT. And then you have to have a database ID. So we have actually requested all that information for you guys. One thing that I need from you guys is to let us know what COTS product you're using, because that changes the database ID configuration. And then actually we were going to have our staff reach out to your staff to set up a meeting so that we can get the information to you guys, and then we can talk about file structures so you can start exporting your data.
Okay, we'll follow up.
Okay.
Okay, thank you, Christina, for the presentation. We have a speaker gift for you. It's right here.
We'll send it
I
out.
can't see. We'll send it to you since you're not here.
Just put it in the office.
Yeah, we'll probably
I'll
do
get it
that.
at some point.
Let's see. Please remember, for everybody, please remember, before you exit the conference today, we have some networking opportunities at our raffle going on for the next 15 minutes. You must be present. You must be present in person or virtual at the closing session of each day to qualify for raffle prizes. We look forward to seeing everyone again tomorrow morning. Make sure you fill out the survey in your packet and drop them off at the registration desk. Okay, and that's it. Thank you, Christina.
Thanks, guys. Enjoy the rest of the conference.